And over to you, Dr. Sweetland.
Thanks so much, Caroline. It has been one of the highlights of my year to work with the Interact for Health team. Such a warm, welcoming, smart, and committed team. So delighted also to be able to contribute to the thinking of our community. So thanks for the opportunity. My topic today is framing health justice or health equity. I'm going to talk through some fundamental practices, but also fresh insights from recent data. What we'll do today is I'll just take a moment to introduce framing and the Frameworks Institute. I'll do a brief review of some new resources, do a walkthrough of some key framing strategies, and I hope to have time at the end for some open discussion. As we're going through this, please, if thoughts and reactions occur to you, please put them in the chat. That can be a question, it can be a reaction, it can be a connection to the content in the chat. And I will be sharing my slides, and Interact for Health will follow up with a copy of the slides, a recording of this session, as well as links to any resources that we end up mentioning during our time together. All right, so I hope that's what you signed up for, and let's get started. So as Caroline mentioned, I'm joining from the Frameworks Institute. We are a nonprofit organization focused on ensuring that mission-driven communicators can lead productive public conversation on the issues that face our nation. We do this through conducting and sharing open source framing research and by partnering with NGOs and public sector agencies to frame things more effectively. And what do I mean by framing? Well, these are choices in how we present ideas. It's the process of making choices about how to present those ideas, and that can involve where to start, what to emphasize, how to explain it, and often what to leave unsaid. We know that the way we frame health topics in particular influences how people think and feel about them and what actions they're willing or not willing to take or support. And as frames move through society, they shape the issues that the public and policymakers pay attention to. And whether or not a public response is seen as appropriate or it's just seen as people's personal troubles to deal with on their own, it shapes, right, how we decide to act or not act as a society. So framing at a simple level is making different choices about how we present things, present our ideas to get different responses in how people, difference in how people respond. And we help people with this by help our partners with this by conducting original social science type research to lead to empirical answers to the questions that perplex us, like how do I talk about that? So here's a quick example from some work we did in Missouri a couple of years back. We had a super easy task, which was to figure out how to have productive conversations about gun policy in the state where the NRA has its Hall of Fame. So with a state with a very strong gun culture. And in one part of the study that we did, we gave small groups short texts formatted like an op-ed that took different lines of argument on these. And so these were like headlines. One was a very scientific tone, a very public health tone of voice. New research reveals the impact of gun violence in Missouri. And the second is a little bit more of a value statement, right? Surely, no matter what we may disagree on, we can all agree that reducing gun violence would do Missouri good. And so when we ask people to imagine themselves at Thanksgiving dinner, starting a conversation about gun policy with guests who are more pro-gun than themselves, and they had to select kind of one of these ways of framing the issue, here's what we heard people say. So the data-based approach was viewed with suspicion. Whose research? Who did the study? Who paid for it? The conversation quickly turned to a conversation about science and bias, not guns or solutions. But a different approach that surely we can all come together and think about this was viewed as inclusive and getting past political beliefs, and participants envisioned a productive conversation following. So that's an example in how we can frame things. And I think this is a particularly important lesson for those of us in public health that are really, careful and for good reasons, right? To work from the data, to speak to the data, and that's important, but the data doesn't speak for itself. So one framing lesson, one framing 101 is to ensure that we're thinking about the data we have, not as the entire dish that we're offering the public to explain things, but more like the seasoning, right, in our dish. It's important. It makes the messaging come through. It's an important element, just like the salt in any dish. But if we just give people the spoonful of salt, we're going to get a negative reaction. So that's one example of what we mean by framing. Another very basic thinking about a very fundamental practice in framing is thinking carefully about the way we assign responsibility for a health topic or health problem. So on the left, you can see this, there's the attribution of responsibility, the claim about who or what is the cause of the issue. It's left open, right? In the US, too many women are suffering from pregnancy complications that lead to serious injury or death. It doesn't say at all who or what is responsible for the problem or the solution. And our research shows that that just leaves way too much room for interpretation, which is room for misinterpretation. For instance, people are likely to fill in either an individual attribution, well, those women probably weren't doing the right thing, or fatalism, what can we do about it? But we don't have to accept those responses. We can choose the way we tell our story, and we can get measurably and predictably different results. So a simple switch here, the US is failing to manage pregnancy complications that lead to serious injury and death. This grammatically puts the nation as the subject of the sentence. There's a different verb there, right? It's not the women who are suffering, it's not the people who are affected, but it's flipping the frame to focus on who or what is responsible, right? And the action that we could be taking, managing, right? We're not taking it. We could manage it, but we aren't. So that's another example of a fundamental practice in framing. As I started by saying, I was really excited to join the Interact for Health community, but with a Framing 101, I felt a little daunted because over the years, we're about to celebrate our 25th anniversary at Frameworks. We've conducted original social science research on really dozens of health topics. And I think Caroline has a link to this issue page that she can pop in the chat if she hasn't already. But you can access the research if you're working on one of these topics or others. It's likely that we have insights that can be helpful to you in understanding the choices that you're making already, understanding how they might be interacting with people's pre-existing understandings and beliefs about the issue, and tested evidence-based ways of talking about the topic in ways that move people's knowledge, attitudes, and their policy preferences in evidence-aligned directions. So I'm not going to go through all of these topics today, but I am going to dig into one that I imagine is top of mind for many of you, whether you're working in government-based public health or at an NGO that is focused on improving community health through another type of strategy. I'm sure you've noticed that the concept of public health writ large is really a difficult, we're in some difficult times post-pandemic. So here are a few, headlines taken from different parts of the nation over the last year or so, whether or not we're up against legislator initiated efforts to undermine or take away government public health authority, whether or not we are experiencing the effects of the politicization and mischaracterization of the term equity or health equity, or whether we're just dealing with the fact that so many of us worked so hard during the pandemic that turnout in mental health and public health among those professionals is really under challenge. challenge. And that's even worse, made worse by the fact that so many folks are skeptical, distrustful, and even hostile, right, to folks trying to do good work in this field. All of those things are really facing us all. And so the National Network of Public Health Institutes was hearing these challenges from public health institutes and local public health departments across the nation and came to us asking these questions. How is it that we can shore up and restore trust in public health? How is it that we can strategically advance conversations about health equity or eliminating health disparities in the efforts to suppress those conversations? And how can we work on these issues together, although we are dispersed, right? Whether or not you're thinking about this nationally with, 1,900 or more public health departments, or even just thinking regionally with the dozens and dozens of many good organizations doing amazing work on health in the greater Cincinnati area, it can be difficult to coordinate and concentrate efforts to shift public thinking. But we also know if we don't coordinate and concentrate those efforts, we're unlikely to make a real big dent in the ways people are thinking and talking about these issues right now. So I'm excited to have some insights from the studies that we did in partnership with NPHI with funding from the CDC to tackle some of these issues. And so I'm going to spend a good portion of our time today talking through some of the things we explored and discovered in this most recent project. And Caroline, if you've got the link to the second thing, this would be a great time to pop that in maybe. So we've recently, in just the last few weeks, shared out a playbook that walks through a strategy for talking about health disparities in ways that really resonate in unlikely audiences, a toolkit that isn't kind of turnkey plug and play messaging for you, but lots of examples and lots of tools that you can use to create your own communications. And then I am the world's nerdiest YouTube star, apparently. A few videos that kind of explain some framing for folks that like to learn or share things out that way. So let me talk through the evidence base behind these and then what we are finding and recommending. So in general, as I've mentioned that we are social scientists, so I happen to be a linguist. We have anthropologists, psychologists, political scientists, sociologists, et cetera, on staff. And so we're not just collecting evidence on did people like that message, or we're not doing traditional audience marketing research, but rather thinking at a deeper level, describing how people think now, and then developing and empirically testing ways to spark new thinking. And so across lots of studies, we work through those two main phases. In the research I'm sharing today, the project I just described in partnership with NPHI, this study inquired over 6,700 Americans. We talked with stakeholders working in local public health across the nation to really begin to understand the challenges and what they saw as their key priorities of ideas to get across. One thing that came up in those, and I'll say more about this later, is that many folks are working in rural areas or areas that have a lot less racial and ethnic diversity than we might find in more metropolitan areas. And so those folks particularly wanted ways to talk about health justice, health equity, health disparities in ways that could resonate and really fit the area, and also be more attentive to the fact that people's perception is that those spaces are not very racially or ethnically diverse. That isn't always the case, but that's certainly the perception. So we started to set out some of the challenges we needed to solve for in terms of framing. We then did something that looks a lot like focus groups, where we took people from rural areas in the four corners of rural America. So I like to think about it. We talked about the Midwest, the Pacific Northwest, the South Atlantic, and the Southwest. And so we talked to folks there and found out how they were thinking about health issues and those sorts of things. With that descriptive sense of what do people want to say, what's the story people want to tell, where are they finding challenges, and how are people and how are their audiences thinking about those same topics, we then moved into the prescriptive phase of this inquiry. So we begin by starting to create some tools and some hypotheses. Well, if the experts are saying, the advocates and experts are saying, we want to talk about this issue and the public is not seeing a connection for them, well, that means we need to build up some understanding. We start to do that kind of tool to task kind of thinking. We then took that into a national survey experiment with a rural oversample. So there was about a third of the participants were rural in each condition, that each kind of message we were testing. And then we dug deeper into understanding the why behind the results that we see quantitatively, with additional focus groups, which we call peer discourse sessions. And again, those folks were rural. If you've got questions about the methods or the sample, I'm happy to take those in the chat, and I'll just pause and see if anyone has a burning question about those before I move on. Also, interact friends. I see somebody's waiting in the waiting room. All right, doesn't look like there's any burning questions about methods there, so I'll get into some of the findings and recommendations. And my first recommendation, I think this cuts across all health topics and really all social issues, is that it's important to anticipate the mindsets that you'll need to navigate. Our audiences are not blank slates. They come with pre-existing understandings, attitudes, and beliefs and assumptions about the topics we're communicating about. And so if we aren't anticipating the mental machinery people are using to interpret what we're saying, we're really leaving a lot up to chance and leaving a lot of room for miscommunication and misinterpretation. Another way to think about it, and this is a graphic that probably many of you seen from our good friends over at FSG, a social change consultancy, is that if we're thinking about changing systems, there are a lot of conditions that we need to think about, a lot of areas of work we need to tackle thoughtfully, but often simultaneously, or at least in connected and thoughtful ways. When we think about changing systems, we often first go to what are the policies, right, that are governing it? What are the practices? What are people actually doing in that system? Where are the resources? Where's the money? Where's the people? That sort of thing. And that work is important. It's explicit and it's tangible. But if we don't pay attention to the relationships and the connections and the power, right, those moving the physical things is only going to get so far if you don't think about the people involved. And then even deeper than that, if you don't think about the mental models inside the people, inside the culture of a system, you're really not able to change it at a fundamental level. And so understanding those mental models is a real strategic advantage for us as systems changers in whatever role we're playing, but also in terms of communications. And so across our research on lots of topics, we found that these mental models often are holding problematic systems in place. They might play out a little differently or there's more specific versions of these for different topics, but they are individualism, fatalism, and otherism. So individualism, the sense that the causes of social problems and their solutions lie pretty much at the level of the individual, that our personal choices, that our personal behaviors really predict and cause the outcomes that we'll get. Now, of course, I'm not saying that individual actions don't matter, but this mental model, if it's because we use it so often and we rely on it to an overextent, it obscures, right, the role of systems, environments, and really leaves us with mismatched solutions to problems. So if the problem is people making bad choices, the only kind of solution people can see at a broad level is let's give them give everyone better information to make better choices. And that is an incomplete solution. It doesn't get to changing systems. I'll pop over to the other side of the slide here. Otherism is kind of us versus them thinking. This is a sense that, social problems are quote unquote their problems, that these are problems that are far away from us. They're other people's problems, and probably they're having those problems because of a failure of cultural values or some sort of pathology within that group. This really leads to zero-sum thinking. It's the underpinning of a lot of racist and xenophobic and sexist thinking, et cetera, a lot of oppressive thinking. And so that leads people to feel less responsible, less of a collective responsibility for social issues, and a lot less thoughtful way, a lot less energy for engaging affected communities and solutions to the problems that face them, because in some ways they're seen as responsible for those problems. And then finally, fatalism, the sense that our social problems are too big to fix. The things are broken beyond repair, they're out of control. We can't count on government or other institutions to really be able to make a difference. And so while we might sometimes think, kind of feel that way, like, wow, we've got a lot of work to do to make a difference in the issues that face us. We find that when people are operating from this way of thinking, it's really hard for them to support social solutions, to support policy solutions. People want to kind of just throw their hands up with a sense of overwhelm, walk away, and worry about kind of me and mine. And so these types of mental models are the ones we're working against often. And so I'm just going to give you a quick peek, and would love to see any connections and hear if these resonate. This is from national research. Love to hear if folks in the greater Cincinnati area are finding these resonant and relevant in your context. So if you'd like to pop that in the chat, I'd love to see it. But next, I'll show an example just to give you a little bit more of a sense of how these mindsets shape thinking. These are this is a compilation of moments from those focus groups I told you about, and it shows you, it's just I don't know, maybe 30 seconds long or so. It shows you kind of the individualistic mindsets at work across the nation, across whole lots of different types of people. So let me get that going. Ooh.
To have good health is to maintain and take as good of care of your physical body, mental.
Eating better, being particular about the food that you consume. And so it starts there.
You have to be concerned about having good health and eating right and diet and exercise. And, if somebody doesn't want that in their lives, there's nothing you can do that's going to change them.
It's a combination. It's your diet, it's your exercise.
You're healthy as long as you're able to keep up your health, and it's kind of an attitude.
So you can just see how that plays out, in people's thinking. So what we saw, and as we looked at, this is the recent study that we did, very much backed up what we've been finding over decades, that not that these are the only ways that people have to think, but these are the most dominant ways that people think. Health individualism, health reductionism, the thought that health is just the absence of illness, and health otherism, and this is particularly, this isn't held by all groups or all people to the same extent, but the idea that that people of color and Black communities in particular, this is a very racist idea, but that health disparities exist because of flaws or patterns of behavior in those communities that are reflective of poor values or those sorts of things. And then finally, this last one is a mental model that's a lack of a mental model, unconnected dots that we found that people had ways to think about, for instance, that being economically disadvantaged, or poverty in public parlance, or it made sense of how people who are have less money or who are quite poor could have health challenges. They are like, well, they can't get to the doctor, maybe they can't afford good food. Those aren't a full explanation of why that happens, but people did have, right, stories that they could tell about that, ways of making sense of it. We did not see the same sort of ways of modeling it. People just didn't have a way to connect structural racism to people's health. So our strategy, kind of as we think about what we want to get to, we want to move mindsets from health individualism into mindsets that environments matter. We want to work against a very narrow conception of health and expand people's sense of health as a sense of overall well-being. And we want to get away from us versus them thinking and deficit-based thinking about the communities that are experiencing inequities that show up in health disparities, and instead emphasize our shared fates and systemic responsibility for ensuring that everyone is doing well. And we want to move from unconnected dots to connecting the dots, give people ways to see how structural racism in particular affects health. And overall, we found that this feels like a tough challenge, but these are doable. These are mindsets that can be built and can be moved. We found the most effective way to do that it's going to require us to restructure the way we order and what we emphasize in our outreach and advocacy communications. So overall, we found that it was important to lead with the idea of dignity. Here I mean center this as a principle, an ideal of honoring people's inherent human dignity and valuing each person and their health and each community and each community's health, and doing that consistently across communications. Step 2, we found it was really important to expand people's mental model of what health is, really use and what health disparities are. Use explanations to expand people's ideas, talk about health as overall well-being, and I'll give some examples of that, and really highlight the importance of access to specific resources to bring that equity and justice dynamic into view. Step 3, speak to history. We need to build motivation for change by explaining how past injustices have harmed specific groups' health. But it's not okay to just leave that in the past as if it's not affecting today. We need to connect the past to the present, linking those past injustices to current health inequities. And we found that using rural-specific policies was an entry point to understanding with more rural and conservative audiences. And then step 5, point to the future. Right now, it's not just you. Americans of all sorts are having trouble imagining positive futures on lots of topics. And so when it comes to health, it's important that we use vision framing to point people towards the possibility of change. I see a little activity in the chat, so I'm just going to take a moment, take a breath, pop in there, see what I missed, and then we'll move into these. Okay, Kobe, I take your point. These are dominant mindsets and not the only mindsets available to any of us in American culture, and certainly not shared to an equal extent by every cultural group, but they are widely shared. And lots of folks have access to them and rely on them at times. I don't think it's not entirely explained by demographics. I'm happy to geek out about that more if you like. All right, so getting into this, leading with the idea of dignity. So when communicating about health disparities, it can be hard to know how to begin, or at least hard to know how to begin effectively. Many of us, if we were work trained in public health or in a aligned field, we were trained to start with the problem, and that often meant starting with statistics. But we found time and again that stacking up a lot of stark statistics about just how bad a problem is can lead the public to tune out. It taps into and reinforces that mental model of fatalism. And when it comes to health disparities that cut across lines of class or race or gender expression or sexuality, if we share data about disparities affecting those groups without context on where those disparities came from, that leaves a lot of space for people to rely on toxic and harmful stereotypes. And that's especially damaging when the health topic itself is stigmatized or sensationalized. So, what can we do? How do we start? We've found that it helps to lead with a values-based message by expressing a cherished ideal or principle. When we express a value early in a communication, it shapes how people respond to the ideas that follow. And many of you, if you're in the Interact for Health kind of network and you're here today, I'm guessing that equity is a strong value for you, and it is a strong values message. But we also know from conversations with many of you, many folks like you across the nation, that this term has become politicized. And if it isn't outright banned, which it is in many places, and maybe happening more given the results of the recent elections at the local, state, and federal levels, if it isn't outright banned or isn't banned yet, it often is a distraction. And so that's why Frameworks researchers went on an empirical quest for values messages that reach and resonate with people who have been exposed to negative mischaracterizations of what we mean when we use terms like health equity. And we tested several possible values frames in a large-scale controlled survey experiment. And we found that reminding audiences that everyone should be treated with dignity is both powerful and effective. And those results were especially strong among people who lived in rural areas. You can see the results of some of this testing here. So we tested two framing strategies so that we really want to ensure and believe that each and every person has inherent dignity and worth, and our policies, our health approaches should reflect that. Or one that talked about how we have such tight-knit communities, particularly in rural areas, that we want to ensure that everyone in that community is okay, and really honor that cohesion. So two different ways of framing the issue. And we had 3 different outcomes, selected outcomes that I'm showing here today. One is a sense of collective efficacy. So it's kind of the opposite of fatalism. So instead of, oh my God, no, we can't, collective empathy is, yes, we can, we could make a difference. A second outcome was systemic factors affect health. So it's kind of the opposite of individualism. It's that more collective environmental way of thinking. And then the third outcome was a more specific version of efficacy. So not just we can make a difference on health, but this one was we can make a difference on racial disparities in health. And you can see that the tight-knit community message frame did not make much of a difference. None of these, the first 2 results are not statistically significant. The third, it did help a little bit on collective efficacy on race. But you can see that dignity far outperformed. And this is a really robust finding for this type of experiment, up to close to 10 points difference compared to a control group in terms of people saying, the system matters, we can make a difference, and we can make a difference on racial disparities. So strongly recommend opening with some version of this value message. And so what does that look like? Here's a short version of what we tested. And our recommendation is to open each communication on health equity topics by expressing, don't talk about health equity so much, talk about honoring people's dignity and valuing each person and each community and their health. And then return to this value across the communication, especially when you're mentioning a specific group that lacks access to a building block of health or faces negative environments or outcomes. Talk about your proposed health policy or health program as a way to demonstrate and live out our respect for dignity of people and communities. So what that might look like in terms of changing a communication, on the left, it really focuses on, so I'll just give you a moment to read that while I take a breath. Okay, so on the left, it talks about kind of how much of America is rural folks. It kind of gives a sense of it trying to collectivize the issue by talking about all the different rural areas. And then it leads into the challenges, right, that affect those regions. We could change that, which is kind of like, there's a lot of folks that are in bad situations. It's particularly bad, and it's really hard to solve because we got additional problems. I'm worried that this would lead to a sense of fatalism. But the value of dignity, we might get our research suggests we'll get a different response. It might sound like this, because every community has dignity and worth. Every action we take should honor it. Treating people with respect involves valuing health and well-being in every community. Right now, our policies don't show respect for rural Americans, who make up at least 15% of the US population. Our collective decisions have led to a rural America with too few good paying jobs, transportation options, or nearby places to get nutritious food. That mix of policy problems contributes to health problems, which are further complicated by limited access to health care. So this leads with that ideal of dignity. It firmly attributes responsibility in the policies that we've decided, and it leaves room for a sense of what we could fix. And so it doesn't make the whole thing about healthcare. It talks about kind of some of those wider drivers of health, and but really, leans into this idea of showing respect for communities. I'm going to give you a little peek into a focus group that showed people responding to this value when exposed to a message like this. This is how people responded. Oh. I'll take just a second for the sound to come on.
Our focus would be to give the dignity and respect back to the community.
Beyond the simple actions of building and ownership, it comes down to a matter of dignity and respect.
Treating me with dignity would be providing me with those resources so that I could live a long and prosperous life.
This isn't a handout. We're all in this together. Then you end up sort of not having a wrong side of the tracks anymore because of that piece of dignity and respect.
Instilling resources into us builds you up and empowers you. It makes you want to do better.
Give them community affordable housing. Give them that respect and that dignity so that they feel like they're a part of the community and not just living in a shack.
Okay. So you can see that really led people to think more about all the things we could be doing as a society to demonstrate respect for people and their health. It got very much away from that health individualism you saw in the first video, and got people thinking about the outer circles of the socio-ecological model, which is no mean trick. All right, a second step in this reframing, if we're thinking about restructuring the way we communicate about these issues. It's important that we offer an expansive explanation of health as overall well-being. That just means adding some descriptors like mental and emotional well-being when possible. Be sure to talk about the health of communities as well as individuals to build an understanding of what community health looks like, and highlight the importance of access to specific resources to bring health disparities into view. And connect this discussion to specific public health policies and programs to demonstrate what needs to happen to address disparities and provide resources that support every individual's and community's health and well-being. So we know that people think of health as just the absence of illness. They tend to think about, if we're thinking about solutions, they think about healthcare. And of course, we want healthcare for folks, but that's not prevention, right? That's treatment. And if they think about prevention, they think about diet and exercise, personal choices. We want to expand on this. We want to get people to think bigger and broader. And so that's just language like this, right? Talk about mental, emotional, and physical health. Don't just say the word health because people have a very narrow view of that. When you prompt them to think more broadly, people can and do. People are ready to go there. But we have to do some prompting in order to bring that out. And then connect that broad view of health with a broad sense of the influences on health. Please stay away from the jargon of the social determinants of health. I can give you a whole riff on that if you want it, but help people think about the social determinants of health in more plain language. People need access to resources like good housing, reliable transportation, safe places to live, work, and play. So with that bigger picture of health, and then you want to pivot into or move into why that's not happening everywhere, how that's not happening everywhere. So you can offer that expansive definition of health, then introduce the ideas of disparities and the underlying inequities that cause them. Once you've introduced that idea, for instance, uneven and unfair access, give a clear, relatable example. Here on the screen, I've got decades of disinvestment in a rural Main Street. You could make that, if that's not right in your context, talk about disinvestment in an urban community over time and what that's meant for the community. Then once you've got that process in mind, speak directly to the groups who have been marginalized or minoritized. And you can include the theme of dignity there. All right, so a lot of this is just about setting the stage, really inviting, painting and like paving the path for people to get into this idea of inequity and injustice, disparities, and solutions. Then it's really important to help people understand how we got here and where we can go. Using a past, present, future arc, we found was highly effective. We were getting rural Republicans, right, saying, yes, we want policy change to improve health in very productive ways with this kind of arc. And it's even more widely resonant with folks who have different types of identities you might think of as already more closely aligned with the health justice perspective. So here's places where you can put your data, lots of examples of how to do this in the toolkit, but the idea is give us one or more specific examples of historical policies that help to explain contemporary health disparities, then connect that past to the present, show how that prior policy established conditions that shape health disparities now. And then, and finally, but not last but not least, that's a phrase I'm looking for, point to the future. And we really need to give people an aspirational vision of what it would look like if we got this right, because so often we're unable to imagine that in our culture right now, because so many places there's just so many examples of where we haven't gotten it right yet. So digging into that, speaking to history is essential to a strong frame on health justice topics, as many advocates have long known. This isn't exactly like connecting history to present disparities, isn't exactly an original idea of frameworks. But there is something new here for all of us, the finding that the way we present history really makes a difference. In particular, we found that there's a huge difference between asserting a historical cause and explaining how the past is affecting the present. And let me show you what I mean by the difference between assertion, and explanation. So on the left, today's housing patterns continue to reflect past discriminatory policies such as redlining, and leave communities of color facing increased health risks, and then a list of what those risks are. This is true, but there's no why there. And so the audience has to kind of take your word for it, or you're hoping they already kind of know this and agree with you. And that's just not the case. But we find that even if they don't already know this or don't already agree with it, that the explanation on the right side can really move people. Backing up into just kind of giving some background, in many US neighborhoods today, residents tend to be from the same racial or ethnic group. People are like, yeah, that's true. Well, why? These patterns exist because they were literally drawn on maps as part of a past discriminatory federal policy known as redlining. And then getting into the present, these policies influence health in communities of color today because neighborhood affects access to quality food, healthcare, and more. So that's that speaking to the past and moving into the present. We saw that speaking to history, doing just that, explaining it rather than asserting it, reduced people's sense of health individualism by a like 3-to-1 margin. Just asserting history is statistically the same as saying nothing. Giving people examples and explaining it is doing a lot. Redlining is a canonical example of the go-to example of how history affects the present for so many reasons. And we found that it was effective in our survey experiment. And we also heard from people across the nation that in rural areas where residences are more scattered or redlining was applied in the same way, it might be helpful to have other historical examples at hand. And so the toolkit illustrates 5 other historical policies, things about why do we not have internet in the country, how transportation, right, affects rural areas, focusing on that key framing move of explain it, don't just name it. So once we have spoken to the past and how it affects today, we want to point to the future. It's really important that we point people to the possibility of change, give people a vision for the future that respects people's dignity and creates equitable change, and center the agency of local communities in making this vision a reality. Like together with communities, we can work and this is what we can get, not just Pollyanna, like one day, it'll be beautiful. Instead, a vision frame is describing what a just and equitable future looks like. And it's about invoking a sense of togetherness and a possibility for change. And we found this was especially effective for people living in rural areas, helped people understand the structural factors that affect health and gave them a sense that as a society, there's something we can do about it. Here's what that might look like. Together, we can create a future where all our communities are treated with dignity and have the resources needed for good health. We can make sure that good housing keeps people safe from extreme weather or poor air quality. We can make sure that transportation easily connects people to work, school, care, and community. And we can make sure that every community can readily access nutritious, affordable food and get the health care they need in the ways that they need it. This kind of framing, sometimes to me, it feels a little, I don't know, fluffy or I don't know, something. But I'm persuaded by the hard evidence that this has strong effects. Talking about that end state helped people, it reduced us versus them talk when the topic turned to the aspirational future. And it built a sense that we could improve racial inequities and disparities. In fact, it significantly increased collective efficacy on racial disparities, 10% over the control group, which is a huge difference for this type of study. All right. So overall, we want to think about, if I just to recap that, leading with the idea of dignity, painting a big picture of health, walking people through explaining history, past, present, and future, and really centering community agency and all of that. Those are kind of my thoughts for the day. I believe we want to move into discussion where people can raise their virtual hands to be acknowledged and come off mute, or you can put questions, comments in the chat and we can discuss them. But also, as you're doing that, or even before you're doing that, please, please, please give us your feedback. We really do look at this. This is, as I mentioned, this is relatively recent resources. So I, would love to hear about how they are landing and if there are questions or challenges that they leave unanswered. So now is the time to move into our conversation. And Caroline, I see that. Thanks for flagging that. It looks like maybe Alexis asked about reframing as like as a messenger, right? The role of messenger. So if I'm talking about if I'm from the city and I'm talking with rural audiences, suburban audiences, or from one city speaking to another, I think that's important to recognize. I mean, even just the question, right, shows you're on the right track for getting that right, understanding that messenger is part of the framing, right? It's not separate from, but it's part of the message you're sending. And so you can't change who you are. Sometimes we're in situations where we can strategically place and deploy and enlist the right person to deliver the message. But sometimes, we are speaking as a position of the outsider. And so this is some things you can do is make sure it's a two-way conversation, right? Invite people's thinking right before offering your own. Demonstrating care and concern. You don't have to wear your whole heart on your sleeve or share your whole personal story. In fact, that's probably a bad idea. But you can put little things as somebody who really cares about my community. I know that I want to bring that care to yours. Or as a mom, I want to ensure that all kids, have a chance to thrive. Just little touches like that can go a long way. I won't say more than that, but please tune in, dig into our resources on messengers on our website. There's lots more there. Grace, good question. What advice do you have for addressing audiences that are resistant to change or hold opposing viewpoints? I think it's important to distinguish, are they persuadable or not? And by definition, your immovable opponents are your immovable opponents. And so thinking about, right, what's the work to be done with or in the context of immovable opponents, often they are not your audience. The people who they could persuade are your audience, right? Kind of the persuadable middle, or even the skeptics, right? Who might be a little closer to them. So thinking about strategically about who is your audience and being clear about the change you need, I think is the strategy there. This whole set of resources that I just went through is basically advice for addressing audiences that we know are persuadable but skeptical of a health justice or health equity kind of initiative. So happy to dig in more specifically if that didn't fully answer your question, or if you want to speak up and say more about it, we can continue that. Anything else? I'll say that the playbook, the toolkit, and the YouTube playlist are all available now, as are more studies on effective framing of health topics than you have time to read. So, just please remember that next time you've got to build a communication on a particular health equity issue, just put in our, check out our website, see if we've got some advice there. You can't take it all in at once, but you can learn it, kind of as you go. And then finally, I'm sure many of us has noticed that health has become a hot topic at the national level now, with some of the incoming administration's thoughts on direction for Department of Health and Human Services and some of the agencies under it. And so on December 5th, I'll be offering or leading, engaging in a national conversation. We're expecting many hundreds of folks on that call, just trying to make sense of this moment. What are the mindsets that leave people vulnerable to misinformation about fluoride or vaccination or food dyes or whatever it may be? How can we ensure that no matter what's going on in the surround sound, we are communicating in ways that cut through the chaos and really keep people engaged and motivated to move in the right direction on health. All right, well, if there are no other questions, I don't know, Caroline, anything you wanted to add or ask about or say?
Yeah, I'd just like to invite folks to take the survey. That helps
Yeah.
inform future sessions like this. And thank you so much for joining us. Feel free to reach out to our team if there are any questions, and keep an eye out for the email with the slides and recording of this session.
Okay, thanks so much for joining, y'all. It was lovely to have a chance to share this.
Thank you, everyone.
Ooh.